So I had a patient who was a Duke professor, lecturing on stage, collapsed, and then came into the ED. They couldn't get the VL or DL.
That moment, I can't really describe the feeling I had, but it was almost surreal. I just couldn't believe that there I was with a failed intubation in a 26-year-old on my second day as an attending.
There were a lot of people around. There was a large crowd. Everyone's looking at you to get that tube in, and so I was intimidated.
And I remember as an intern, just this feeling of dread, this sense of doom and helplessness.
She does what anybody would do when they have totally lost their airway. She starts flailing around wildly because she is suffocating to death in her own body.
So I had a patient who was a Duke professor, lecturing on stage, collapsed, and then came into the ED. They couldn't get the VL or DL. So they called me over as I was the senior most physician. They called ENT, they called trauma, and I said to myself, you know what? I don't feel totally comfortable opening this person's neck up. It was a little bit larger, so I ended up doing a retrograde intubation. So I used Seldinger technique. I basically put in a big needle, then put the guide wire throughout the mouth, then put the ET tube over, and then unfortunately the cricothyroid membrane and the vocal cords are pretty close, so once I pulled out the guide wire, it just slipped. So I ended up actually going lower into the trachea and then did it, and the patient had a positive outcome afterwards.
My first cric involved a younger gentleman that likely came in as an overdose, was totally unresponsive, and when we went to push intubation meds, had a large reflux, a vomit, mostly had large blueberries, strawberries, and other assorted fruits that came up that we just could not suction at all. And so in that moment, I knew that we had to cric this patient. I remember feeling terrified. I was nervous. I felt a little prepared because we had done a lot of sim. So I knew the steps, and that's the most important things to keep in mind, just the steps of the procedure. There were a lot of people around. There was a large crowd. Everyone's looking at you to get that tube in. And so I was intimidated, to be very honest, and scared. I eventually got the tube in. The patient ultimately didn't make it, but I was really scared in that moment.
We had a patient who had multifocal pneumonia and went to respiratory failure. And after 5 intubation attempts between myself, the senior resident, the quick care attending, and the anesthesia team, we were unable to establish definitive airway. And as a EM provider, I think that's one of our worst fears. I remember vividly this sense of helplessness, just thinking that this man is going to die. And I remember watching him breathing down to the 40s heart rate and knowing that at any time that he would go into cardiac arrest. We made a decision to perform a cric using the reverse Seldinger technique, in which an introducer needle is placed through the cricothyroid membrane and a guide wire is then fed in a retrograde fashion back through the vocal cords. And I remember having my hand in the patient's mouth, fishing for the guide wire as it came through the vocal cords. I was able to grab it and pulled it through the mouth, and I was able to feed a 6-0 ET tube through the guide wire and back through the vocal cords. And just a sense of instant relief that came over the entire room when we were able to establish definitive airway.
My first cric was in a 26-year-old inhalational burn, and I remember this like it was yesterday. Patient rolled in and had an inhalational burn, had some respiratory stridor. I knew immediately that we had to intubate him. I got him all prepped and we had optimal intubating conditions, and I got in there and all I saw was a mash of angry, red, swollen, soot-covered tissue that with no visible identifiable landmarks. I tried a couple of times to intubate and I was unsuccessful. His oxygen level dropped. I was able to bag him with difficulty the first time, but then I went back in for a third look and I really could just not see anything that was even close to cords or something that I could pass a tube past. His oxygen saturation started to drop again and we started to try to bag him, and at that point I was unable to bag him. And at that moment, I can't really describe the feeling I had, but it was almost surreal. I just couldn't believe that there I was with a failed intubation in a 26-year-old on my second day as an attending. I was about to go back up to the head of the bed and to try intubating him again because I just couldn't believe that I was failing, and I just really couldn't feel that failure was an option. And it wasn't until a senior attending, stuck his head in the room and saw the situation clearly from another perspective and said, "Hey, I think this patient might need a cric." And that just triggered something in my brain, and I realized that I was suffering from something called focus lock, which is very common in stressful situations, where I was just saying to myself, this is the solution, I just have to do it over, one more time, one more try, one more try, one more try. And it's one of those classic episodes of stress-induced failure when it comes to difficult airways and failed airway scenarios, just waiting too long to do that cric. Well, fortunately, that attending triggered me to go ahead and grab the scalpel and perform a cric, which I did, and the patient did well with no neurologic deficits.
400-pound woman came in who had angioedema from an ACE inhibitor. She complained of shortness of breath, but when she came in talking like this. And so it was not a real mystery what was going on. Her uvula was gigantic. So we clearly knew she needed an airway. She was satting fine. She was probably about 400 pounds and probably about 45 years old or so. We got her into a room. We put her on the monitor. We paged anesthesia sat. ENT just happened to be there in the ER already, kind of heard this, saw this, and we all agreed that the thing that had to happen was a weak fiber optic intubation. So ENT comes down. They start her with a little acetylcholine. They put the scope into her nose, and as they're advancing the scope, she starts to complain that she's having worsening trouble breathing, and then she kind of just goes silent. She goes like, at which point she had completely occluded her airway. And for a moment she's looking around, and we realize we have to do the cric like now. But after about 5 or 10 seconds, she does what anybody would do when they have totally lost their airway. She starts flailing around wildly because she is suffocating to death in her own body and can't breathe. And so she's like clawing at her neck and flailing around, and you can't do anything in that situation. We had an IV in, we certainly couldn't get to it. I think a couple people said calm down a couple times, and then she did this for about a minute until she fainted. And when she fainted, she was pressed up against the corner of the stretcher with her head like this in a terrible position with this giant neck. And so we had very short amount of time to do the cric, and this woman's neck was gigantic. You couldn't feel any landmarks. So I made a small cut. I tried to kind of move things around, but it was all neck. So we made the cut gigantic. That was the first most important thing that we did. Huge. It's a bloody mess. It's not hemorrhaging blood, but it is a blind procedure. The beauty of it, though, is no matter how big the neck is, how bad the position is, or how bloody it is, once you get through the skin and the soft tissue and the fat, and you just kind of get your hand down fully in there, everyone has skinny cartilage. And so we were able to get our hands on the cartilage. ENT was actually physically holding the part of her neck open so I could feel in there. It was a 4-hand cric. We felt the membrane. We got the scalpel in. We passed the bougie. We bagged her. We got chest rise. She had no pulse, so we coded her. We got ROSC. We sent her to the ICU.
Check it out.
Even though I knew the steps of the procedure, I really just got lucky and was able to perform that in a timely fashion because someone just happened to stick their head in. I didn't have an adequate plan. I really didn't have an understanding of what stress was going to do to my mind, and I really didn't have an understanding for the role that human factors play in our successes and our failures when it comes to crisis situations and deploying our knowledge in moments of stress. So if there's anything that you take away from my experience when it comes to performing crics and failed airway scenarios, is that don't just learn the technique. Learn all the skills that are required to successfully deploy your knowledge, and learn the skills in a way that actually makes them useful so that you can use them when you need them.
So my big take-home messages are A, everybody has skinny cartilage no matter how fat they are, and B, make that incision big, give yourself room to work with. It will only help you.
I think cricothyrotomies come down to 3 basic tenets. 1, the necessity for the procedure. 2, your preparation going into it. And 3, the confidence that you had. Early on, when I was going to do my first couple crics, I think my biggest hurdle was the mental challenge, because if you're going to be doing this procedure, you have to be doing something totally heroic and exposing the neck and potentially putting the patient at risk. And I think that I thought I needed just really good luck to do it. But we know luck is when preparation meets opportunity. one of the things that I realized is now I feel a lot more comfortable about this procedure, and I think I could have saved some apneic time by doing it if I just opened up the neck. And I think I kind of evolved from the phase of, VL, DL, and oh no, I'm kind of scared for the next procedure, to now I feel fully confident. Give me that triple setup, VL, DL, and surgical airway. Some pros and pitfalls. 1, give yourself enough exposure. When you're opening up and making a vertical incision, often there's not enough exposure. 2, it ends up being a bloody procedure. Make sure that you have your suction set up. 3, make sure that you understand the equipment that you're using through practice and preparation. 4, if you can't get through that small space and the patient's about to die or is already dead, then it may be controversial, but you should go through the trachea unless you have somebody who's a lot more skilled around you. We are going to champion you through this procedure, and instead of luck, I wish you good preparation meets opportunity.